Mesdames, Messieurs.
Thank you, ladies and gentlemen. We're going to start the second symposium sponsored by the industry. These symposiums are important because they always propose excellent speakers that are also speakers in the program. The next symposium is sponsored by INDIVIOR. It includes several speakers. My name is Marc GREENWALD. I'm chairing this session. My disclosures. So, those who are going to be thinking this symposium is focused on research data and practical translation. There are three speakers: neurosciences in Michigan, in Detroit, who is in charge of a research team with a specific interest for biomarkers. He will give us data.
And then we have Dr. Fuschia SERRE, who's a researcher, full-time researcher at the University of Bordeaux. I met him a few years ago, and he has brought into the field of addictions, he's brought in a method which allows us to study individual experiences, and she will be presenting some of these data.
Because it is very emotional for me. I'm very proud that we have Professor Melina FATSEAS. Professor Melina FATSEAS has been a long-time collaborator over the past 20 years, and now since a month, since September of this year, she is a full-time tenured professor of addiction medicine and flying with her own wings, which makes me very proud of her achievement and also sad about that. Merci.
Thank you. And so therefore, not to lose time, so the goals are research data and the translation into clinical practice. The program, I'll go very quickly. Each presentation will be about 20 minutes, and we hope, sometimes we're disappointed, but hopefully at the end we will be able to have some time for questions. It will depend on how we manage the time and how much you want to do that. So some housekeeping matters that this satellite sponsor, there's not any fire alarm test. So if you do hear the fire alarm, you have to leave and look for the fire exits. Please silence and put your telephones on vibration. And at the end, there's an evaluation form. And please write down your opinion, particularly critical elements, in order to be able to improve in the future. Without
Bonjour. So today I will speak with you about the neuropharmacological foundation of opioid use disorder treatment, and I have disclosures. I'm a consultant for INDIVIOR and for two other smaller companies based in the US regarding the development of addiction medicines, and my work has been funded for many years by the National Institute on Drug Abuse. So my goals today are to discuss with you the interaction of the opioid receptor system in the cycle of addiction, and to discuss the foundational studies that we conducted going back a number of years that describe the effects of buprenorphine dose, as well as time since dose on the effects in opioid use disorder patients, and to discuss the relationship between opioid receptor occupancy and the plasma concentrations of buprenorphine, and to conclude with the science-based conclusion that we really need to achieve a certain threshold of dosing to really change the game in treatment of opioid use disorder, specifically to achieve at least 70% mu-opioid receptor occupancy and at least 2 nanograms per milliliter plasma concentrations. So I'll give you the data that support that conclusion. So first, just a very brief overview that there are 3 fundamental drivers of the opioid addiction cycle. One is drug liking, which we define typically subjectively as a positive response, and this has been shown in studies to be a close correlate of the propensity to continue taking opioids and other drugs of abuse. And this really reflects the fundamental process of positive reinforcement of behavior, that if you like it, you want to take it again. The second driver is withdrawal. As opioid use escalates and individual becomes physically dependent, opioid withdrawal drives further drug use, really just to prevent the distressing effects of abstinence. And this is what we refer to as negative reinforcement. And craving is the third driver, and that can go along either with positive reinforcement or negative reinforcement, but it is this fundamental desire, intense wanting for drugs. So the opioid receptor system plays a natural role in the brain physiology in our daily life, independent of addiction. It has important features in our response to environmental stimulation. Often we get the release of endogenous opioids, things like endorphins, in response to positive life events, but also to challenging life events, stressors, and so forth. And so the receptors then are already exerting baseline effects on function. The mu-opioid receptors are responsible for the euphoric effects of opioids once individuals begin using. And as use escalates, what we see is that there are adaptations to mu-opioid receptors that are associated with the development of tolerance. And as that process develops and individuals then become physically dependent, that increased signaling in the mu-opioid receptor system is also associated with an increased drive in the kappa system, especially in brain regions such as the amygdala, bed nucleus of the stria terminalis, habenula, and dorsal raphe nucleus, whereas the positive reinforcing effects with mu receptors are associated with the ventral tegmental area and the nucleus accumbens. And so what you get then is increased dysphoria, stress reactivity, anxiety, and this is part of that negative reinforcement process. Together, we know that there's ultimately associated with craving this preoccupation, this anticipation of drug use associated with cues and stress, and that this can drive effects in the hippocampus, which is associated with contextual memory, as well as planning and executive control in the frontal cortex of the brain. We know less about delta opioid receptors and their function, although they are involved in anxiety and mood states. So all of these things become corrupted or hijacked as part of chronic opioid use, and we have a new brain. We reach a new set point of homeostasis in the cycle of addiction. As I said, endorphins are the natural ligands for mu-opioid receptors, and I'm going to focus on mu-opioid receptors from here on out. Of course, we have many exogenous ligands, drugs, that bind at these mu-opioid receptors. We have full agonists, such as methadone, heroin, fentanyl. We have partial agonists, including buprénorphine, nalbuphine, butorphanol. And we, of course, have antagonists that as you increase the dose, you get no receptor activation. These are drugs like naltrexone, naloxone, nalmefene. And what you can see here is kind of what your brain would look like if we were to image the opioid receptors in its natural state in the absence of any drug. And you can see the thalamus here. This has the highest concentrations of mu-opioid receptors. It's involved in pain and sensory processing, in the caudate putamen, in the amygdala, throughout the cingulate cortex. Very few opioid receptors in the occipital cortex of the brain, and we use that as a control region, as I will describe momentarily. So buprenorphine, to focus here, is a partial agonist at mu opioid receptors. So this is an in vitro study in which buprenorphine was applied in a tissue bath, and what we do is we measure the ability of buprenorphine to activate different subtypes of receptors, either mu, kappa, delta, or an opioid-like receptor called nociceptin, across an extremely wide dose range. And what you can see is that in blue, as the concentration increases, mu receptors are activated up to a point, and they reach a ceiling. This is a partial agonist effect. Across that same dose range and even higher, you see that kappa receptors and delta receptors are not significantly activated. That means they're having antagonist effects at that receptor, and that at concentrations roughly 3,500 times higher, 3.5 log units, we finally get activation of nociceptin receptors. Now, of course, clinically, we don't have a dose range of buprenorphine that spans 3,500 times. So at clinically relevant concentrations, the therapeutic effects of buprenorphine are solely due, as we know it today, to partial mu opioid receptor activation. So I want to transition into describing our studies. We use a technique known as positron emission tomography, or PET imaging, in combination with a very elegant radio tracer known as carbon-11 carfentanil, which is highly selective and potent and binds with great affinity at mu opioid receptors. It's the gold standard for doing this kind of imaging. And what we do, just to give you a very brief overview, is to administer carfentanil as an infusion followed by a bolus dose to maintain equilibrium or steady state concentration so we can image in a very reliable and valid manner. After a certain dose of buprenorphine is on board. And then what we're doing is essentially looking at the relative binding of buprenorphine in competition with carfentanil to access mu opioid receptors, the extent to which the brain does not have any buprenorphine in it, then carfentanil will bind to those receptors and light it up and produce this sort of image. So this is in the absence of buprenorphine. That's the same picture I showed you earlier. And receptor occupancy is maybe an easier, more intuitive term, but due to technical limitations of PET imaging, what we purists refer to receptor availability, which is the inverse term. It's the complement. And so if more receptors are available, fewer are occupied, and vice versa. So in our first study, we really wanted to establish for the first time in humans the relationship between buprenorphine dose and mu opioid receptor occupancy or availability. What we did, very briefly, is to stabilize individuals on 4 different descending doses. So each individual participated in the entire 10-week protocol, 70 days. And they were first stabilized on 32 milligrams. Each circle is an individual day, consecutive day in the protocol. This open circles are outpatient days. The closed circles are inpatient days. And they were always admitted on a Monday through Friday. On Monday, we challenged them at each dose with a high dose, 24 milligrams of intramuscular hydromorphone, to see whether the concentration of buprenorphine at that time was associated with the blockade of that effect, whether it served as a deterrent to experiencing the liking effects. We then took a day to collect serial blood samples for pharmacokinetic analysis. We measured withdrawal, craving, agonist symptoms on buprenorphine. And then on Friday, we took them over to the PET scanner and did the carfentanil PET scans. And we repeated this 4 different times at 32 milligrams, and this was all done under double-blind conditions. Then we lowered the dose to 16 milligrams, repeated those same procedures, then to 2 milligrams, and then to 0 or placebo. Importantly, what I'm going to describe to you next, please be aware that when we compute mu opioid receptor occupancy, we have to have this baseline condition in the absence of buprenorphine for an effective control. So I'll show you the percentage of receptors occupied. It will be 2 milligrams versus 0 milligrams, 16 milligrams versus 0 milligrams, and 32 milligrams versus 0 milligrams. The most important takeaway point here is that we see in the overall group, a dose-dependent decrease in mu receptor availability as a function of buprénorphine dose. So at 32 milligrams, we see that most receptors, about 95% of them, are occupied. We have 7 different regions of interest that we specified in advance: in the prefrontal cortex, anterior cingulate cortex, in the striatum, thalamus, amygdala. At 16 milligrams, there was slightly less availability, about 85 to 90%, depending on the region of interest. In the study, we did not do 8 milligrams, but you can see with these sigmoidal curve plots, which are traditional in pharmacology, that we can estimate what the binding would have been at 8 milligrams. And at 2 milligrams is the percentage of receptors occupied there. And this is a representative subject's data here. When 32 milligrams is on board, carfentanil does not bind to receptors. There's no statistical difference when you're at 16 milligrams. You can see receptors start to light up. Carfentanil, or think of any other opioid, can now bind more avidly to these receptors. And at 0 milligrams, we have the picture I showed you earlier. And if you look at individual subjects who completed this protocol, these are extremely difficult protocols to do technically, we see even at the individual subject level very consistent results. There's 3 main takeaway points here. First, for each individual, each line is 1 participant, and these panels are 4 different brain regions that we looked at, just to show you. So this is at the very basic unit level of analysis. Everybody shows a dose-response curve. That's point number 1. Point number 2, you see no significant difference in binding between 32 milligrams and 16 milligrams. A very slight difference, but not statistically significant and not likely to be highly clinically different. And then the third point is that at the 2 milligram dose, you see about a 3 to 3.5-fold variation in mu-opioid receptor occupancy across subjects, and that's true regardless of the region you look in. So there's more interpatient heterogeneity. Also at the individual subject level, we looked at what clinical signs or symptoms might be most closely allied with mu receptor occupancy. And it turned out that we had significant correlations among several of our measures, but withdrawal symptoms showed the tightest correlation at the individual subject level. And so these are individual curve fits, and in each plot, say for this participant here, 5316, this is that person's 32 milligram dose, their 16 milligram dose, their 2 milligram dose, and their 0 milligram dose. So when they're on placebo, more receptors are available, that is, fewer are occupied, and that's associated with clinically significant levels of withdrawal. On this particular outcome scale, anything greater than 10, people start to become distressed and report this. We also challenged with hydromorphone, as I mentioned earlier, and what we saw when we measured symptoms pre to post hydromorphone, we were looking for the extent of opioid blockade. Our goal over here on the right panel is to make that bar very small. So when they were on 32 milligrams or 16 milligrams, we showed opioid blockade, a very small response to hydromorphone, not statistically different from one another, and each of these bars was significantly different from the hydromorphone response when they were maintained on 2 milligrams or placebo, and 2 milligrams did not provide any opioid blockade advantage over placebo. So it wasn't providing that kind of clinical protection that you would want. In our second study, we used similar methods, so I'm not going to go back over that, just to say that based on the results of the first study, we then stabilized individuals on 16 milligrams daily, initially as outpatients, and then we admitted them to an inpatient unit where if they had been using any drugs, we washed that out. We did a 24-hour pharmacokinetic analysis, and then half of the subjects, there were 10 in this study, about half of the subjects got PET scans on the first week, And these were scheduled on consecutive days at 24-hour intervals. So in the first study, we scanned at 4 hours after the 16 milligram dose, and we replicated that condition right here. So the very first scan was 4 hours after 16 milligrams, and then at 24-hour intervals, that would be 28, 52, and 76 hours after the last active dose. What we did is we substituted placebo doses of buprenorphine, again, under double-blind conditions. And we measured symptom reports and plasma levels at the same time. Now, we had to do the hydromorphone challenges to look at opioid blockade on a separate week, because you can't introduce hydromorphone while you're doing the PET scans, because that's another exogenous ligand that's also competing for the mu-opioid receptor, along with carfentanil and buprenorphine. So that would invalidate the results. So we had to restabilize individuals. And then on the other week, for those subjects who got PET first, we then did the hydromorphone challenges. The other half of the subjects had hydromorphone first, and then on the other week after restabilization got the PET scans. And each hydromorphone challenge was done as a cumulative dosing study. We gave them at intervals 0, 6, 6, and 12 milligrams, accumulating to 0, 6, 12, and 24. So we'll just focus on the cumulative dosing at 24 milligrams. And what we see is that mu receptor availability increases over time after buprenorphine administration, regardless of which region of interest you're looking at. We saw dose-dependent increases, regardless of the region. We see time-dependent increases, regardless of the region. Again, this is a representative subject, 4 hours after 16 milligrams. The brain is indifferent to carfentanil because buprenorphine is already there in high concentrations, blocking the access of the carfentanil to those receptors. And then as time since buprenorphine increases, more receptors become available, fewer are occupied. When we look at our pharmacokinetic data, very lawful curves within the 24-hour time period, and at 4, 28, 52, and 76 hours, those concentrations of buprenorphine are highly correlated, especially with an exponential function fit, with the mu-opioid receptor availability across all regions of interest. I'm almost done. This curve right here is what I just showed you on the last slide. To saturate all receptors, you would have to have very high plasma levels, over 10 nanograms per milliliter of buprenorphine. As more receptors become available, so these are the data for withdrawal symptoms, for instance, at 4 hours, 28 hours, 52, and 76, the average in the entire sample, you see a time-related increase in withdrawal symptoms. It's highly significant. And you see with the hydromorphone challenge data, the degree to which there's a change in symptoms in response to hydromorphone represents the lack of opioid blockade. That's an undesirable effect. And so with time since buprenorphine, more withdrawal, less opioid blockade. So when you consider all of the data together, all the symptoms and how it relates to the receptor availability, we come to this summary here showing, and I'm going to just run right to here, that with withdrawal suppression, you need a minimum threshold of 50% receptors occupied to be able to suppress withdrawal. Historically, we think that's been associated with dosing of around 8 milligrams a day. Okay, so that's enough to do withdrawal suppression, but it's not good enough for other types of effects, specifically blockade of the opioid euphoric effects. We need a higher dosing threshold to be able to achieve this clinically desirable opioid blockade effect, and our estimates are that we need about at least 70% of mu-opioid receptors occupied to achieve that higher threshold that will produce a deterrent effect to continuing use and to break the cycle of addiction. And to summarize in one slide, we've seen that mu-opioid receptors occupancy is dose-dependent, it's time-dependent, and that optimal dosing is going to be really critical for achieving this clinically desired threshold of receptor occupancy. Receptor occupancy correlates very closely with plasma levels. We can construct very tight functions at the individual subject level to show this. And that 2 nanograms per milliliter concentration of buprenorphine in the plasma is associated with this higher threshold of at least 70% mu receptor occupancy. And finally, that maintaining this therapeutic threshold is critical to addressing the three drivers of the cycle of addiction: craving, liking, and withdrawal. And so we want to target these higher thresholds because underdosing has adverse consequences in terms of allowing individuals to continue use. So with that, I will stop and pass it on to the next individual.
Thank you, Marc. Merci beaucoup pour la présentation. Donc, on a vu.
Thank you very much for this presentation. We've seen that we were right inside the brain. Now we are going to discuss research where we look at the impact on the brain on a number of substances. Something else that I would like to mention for those who arrived late. This is a symposium satellite for INDIVIOR. The sponsor is INDIVIOR. The second piece of information that I would like to remind you, to avoid any misunderstanding, is that each speaker was responsible for his or her presentation and for the data that they provide. And so it's important that you know that before they speak. So they're responsible for what they say. Now, we're not so much going to talk about what happens inside the brain, but outside. We're going to listen to Dr. Fuschia SERRE. She's going to discuss pharmacological data on psycho-behavior. Well, thank you for giving us the potential to discuss our research data. In my presentation, I'm going to provide information from the cohort named ADDICTAQUI. So this is real-life data in which we try to assess the relation between the doses of buprénorphine, craving, and severity of addiction. Now, before we start, I'm going to describe the cohort. This is a cohort in the region of Aquitaine, so in this very region, which was created in 1994. It includes patients seeking treatment for addiction to substances or behavioral addiction. And so they are addicted in the hospital of Champs-Pérens or in the hospital in Bayonne. Since 1994, more than 4,500 patients were included. On average, we include 250 patients a year. The objective of this cohort are the following. We want to assess the impact of treatment on long and medium term. We want to understand the outcome of those patients and try to also predict their outcome based on their criteria at baseline. We want to be able to compare those characteristics depending on the type of addiction, and on the long term we have to have a better understanding of their addiction and how they fare. Very quickly, the method that we've used for this method. So the subjects are assessed at baseline, then at 3 months, 6 months, and then every 6 months, this irrespective of their treatment schedule. Then at each of those assessments, they're going to go through a number of steps, a number of questionnaires. The Addiction Severity Index. This is an interview during which we collect information in different areas to try and have a severity profile, so the different domains or areas of life being impacted by the addiction. So information from a medical point of view, psychiatric point of view, social, family information, but also the use of substances, their addictions, and also the history of medications. Then we also perform urine testing to detect the abuse And since 2006, we have started also assessing craving, so how many craving there have been in the last 30 days. We also had other questionnaires to have a more comprehensive snapshot, the MINI, to try and assess the different conditions, and a number of self-administered questionnaires on the quality of life, to name but a few. Now, the first study that I'm going to present is a study in which we looked at the outcome 12 months after treatment for an opioid addiction. So we selected patients who either started with buprénorphine or methadone. So we assessed their characteristics at baseline, and then we described their outcome in a natural environment. And then we compared the characteristic at baseline, and we compared both groups, buprénorphine and methadone. I'm going to jump very quickly because there's a poster outside which is going to provide you all information, so I'm not going to dwell too much. So we had a 173 patients in the methadone group, 110. Our inclusion, at the baseline, the characteristics were about the same in terms of gender, age, comorbidities, quality of life. There was a difference in the substances of abuse. There was less heroin in the buprénorphine group, but more alcohol. At 12 months, most of the patients were still on treatment. The average dose in buprénorphine, 14.5 milligrams, methadone, 89.5. And at 12 months, we do see a marked decrease in the number of users of opiates from 74 to 26. The reduction in the number of days, 20 days out of, I'm sorry, from 20 days out of 30 to 2 days, a very significant improvement in the quality of life. Now, when we assess the severity of addiction, which is measured by the composite ASI score, this is not, so this is on a longer period of time, and we do see an improvement in the severity of addiction. We do see there's a correlation with dose, especially in the buprénorphine group. It seems that a higher dose of buprénorphine is given to those patients who seem to not increase that much, improve that much in the first 12 months. We do see that there's a strong correlation with severity at baseline. And so those with the most symptoms tend to improve more than the others, probably because there's more room for maneuver, as it were. Now, if we compare again the outcome between buprénorphine and methadone, there's a significant improvement in both groups, in the use of heroin, in the number of days without consumption of any substance. Also, there's a significant improvement in the number of prosecutions and in the number of psychiatric comorbidities. In the buprénorphine group, what we see is a significant decrease in alcohol abuse, benzodiazepine and cocaine abuse, an improvement in the ASI score when it comes to alcohol and social family inclusion. So about craving, so we do see that buprénorphine and methadone are interesting and do improve the situation in both groups. And we thought that maybe the impact was mostly on craving. So craving, we defined already. Craving is that desire, this loss of control, and we know that it plays a key role in relapse and also in those behaviors around addiction. And a number of studies do demonstrate the key role of craving in relapse. Now, in literature, there is a clear link between craving and relapse, especially in populations with an opiate addiction. But this is also a result that you find for other types of addiction. In this first study, published in 2015, 49 patients treated by methadone, they went through a session where they were presented with a number of stimuli or stimuli, and so they were seen 3 months later. So we did see, they did measure the results at timeline, but then 3 months later, and there was a pre-Q exposure, a post-Q exposure, and a comparison between pre and post-exposure. And it seems that there's an increase, the increase of craving and the sensitivity to craving seems to be a good predictor to relapse at 3 months. This is another study, 2014, 147 patients treated with buprénorphine, and they show that there's an increase of craving, which is then associated to an increased use of opiates during the 2 following weeks. Same results, another study, 2014 as well. Those patients were followed up upon every week. They were treated for an abuse of prescribed opiates, and there's also an increase of craving when and they use more opiates in the week after exposure. The last study, 2015, they grouped the patients depending on their outcome measured in terms of craving, symptoms, withdrawal syndrome, and we realized that the patients who have more craving at inclusion and compared to those with less craving are faring better. So basically, they are the ones who are going to remain abstinent for a longer period of time. So this all demonstrates the connection between craving and relapse. So if we were to summarize also the results from our cohort, so this is again the ADDICTAQUI cohort, and we compared the results we get in vitro and in vivo. So in the lab, we performed a study quite reminiscent of the one I presented previously. Those patients were followed upon, they were stable, buprénorphine or methadone. And we proposed an experimental session during which they were presented with cues associated to heroin. We would measure their reactivity, and then we would follow up for 12 months. And in the same way as presented before, those with a relapse in the first 3 months are the one who reacted the more to the different cues. So we do see that the relapsers are the ones who are more reactive to the experimental sessions 3 months prior. Also, we try to assess that connection in real life. We used a methodology which is using a platform on mobile phones. And so there are assessments that are performed many times a day, and so we can assess what happens at different moments in a given day. And we see that when there is craving at T0, there's an increased probability that there's a use of substance in the subsequent hours. So there's, in real life and in the lab, a clear connection between craving and more use. From a theoretical point of view, this is of course very interesting because it tends to demonstrate that if we reduce craving, then we have less use. Hence the interest of focusing very much between the dose of buprénorphine and the respective impact on craving. In literature, what we see in the studies. So this first study, 2003, compared to placebo, buprénorphine is very does reduce craving in a significant manner. It seems that its impact is dose dependent. Those are different doses of buprénorphine that were tested, 1 milligram for 8-16. In our cohort, we also tried to demonstrate the connection between dose and severity. First, we performed a number of inter-individual analysis, so a cross-cutting analysis, 86 persons. At 12 months, those with a higher dose are those who still use heroin. The ones with the higher severity index are also the ones with the higher dose, and also the ones with the higher dose of buprénorphine are the ones who are still very severe at 12 months. So there's a correlation between the severity of ASI and the dose they take at 12 months. And so there's a clear correlation between both. I also created categories. Those who receive more than 16 milligrams, far right, less than 8 milligrams, and intermediate doses. And we see that those with more than 16 milligrams are significantly more severe on ASI. So those who receive the highest dose are the ones with the highest severity as well. We also tried to envisage that from a completely different standpoint. We wanted to see what was the outcome when you increase the doses of buprénorphine or methadone, what's the impact on craving. So we performed intra-individual, again, cross-cutting analysis. 29 patients, 2 different time points for assessments. All of them, so in total we had 91 assessments. And what we see is that we increase the doses of buprénorphine. So when the doses is stronger, so that person took many doses, and at some point they were prescribed a higher dose. And so with the higher dose, we did demonstrate there was less craving and less use of opiates. So all in all, if we were to summarize what we see in our cohort, well, we could demonstrate that treatment with buprénorphine is an efficient treatment in real life. We do observe an improvement in the severity of addiction, decrease in consumption of opiates, alcohol, cocaine, improvement of quality of life. At 12 months, the ones with the most severe addiction are the ones receiving the higher dose. And in a given individual, if you increase the dose, it's always correlated to a decrease of craving and a decrease of use. That was me. Thank you. Thank you, Dr. FATSEAS. Thank you for respecting the time allocated to you. Now, we are going to listen to the last presentation by Dr. Serre. Now we're going to listen to Professor FATSEAS. So we discussed the brain, we discussed real life, and Dr. FATSEAS is going to surf, because she's from Biarritz, she's going to surf us through those different studies with a real-life approach, how you should translate those data in real life. Professor FATSEAS, you have the floor.
Hello, everybody. I would like to thank the organizers of the symposium for inviting me. I would like to thank Marc GREENWALD for his kind introduction. And I hope to be able to continue for a long time to add to what I learned in Bordeaux. So I'm going to try now to talk about the elements and the clinical implications of what has been presented by trying to answer the question, how do we translate the research data when we are with a patient? Before talking about the more clinical elements, I'm going to go back in a very briefly to talk about a summary of the data from the research with regards to craving and usage. The research data have allowed us to better understand the relapse mechanisms in addiction by showing the role of craving when addictions are retaken, and particularly for opiates. These are experimental data and daily life data also. Both have shown a direct relationship between the intensity of the craving periods and the apart from this link of craving and relapse, the studies done in daily life have also allowed us to better understand the temporary fluctuations of craving, because it is quick. These are quick fluctuations even within one day. And as you can see on the slide, you can see that the time links and the consumption of substance will occur on fast period of times, a few seconds or a few hours, depending on the craving episodes. Apart from this dynamic, these fast variations, we also have we know that craving is a phenomenon that is very strongly influenced by the effect of many variables, environmental, emotional too, to which the subject will be exposed during a day. And in relatively recent studies, we know also that the phenomena of exposure to stress will have the capacity of inducing craving episodes, and therefore increasing the vulnerability to relapse in the subsequent hours. It's a Preston study that shows that, and there are stimuli that are associated to the consumption of substance, particularly stimuli which are very closely linked to the personal consumption habits of the patient, like being exposed to a friend with whom you were used to consuming, or to being exposed to his own consumption materials. That had a strong effect about the capacity of craving and increasing the relapse risk. Apart from these subject factors, there are individual factors which are much more stable than the inter-subject, and they can modulate the modulation between craving and usage by increasing the intensity of the experience of craving, like, for example, certain diagnoses or biological markers like stress reactivity. We've been able to show that the existence of a psychiatric disorder, particularly anxiety or mood disorder, was very associated to more intense craving and more vulnerability to relapse comparatively to those patients without psychiatric disorders that are associated with psychiatric disorders. So we can ask ourselves, what is the translation of this data in the clinical practice? The first observation is that when we globally look at Europeans and the prevalence of substance consumption in patients treated by methadone or by buprénorphine, we find that in spite of everything, there are about 30% of these subjects who have regular consumption of once a week at least of a substance, and depending on the different of groups, between 20 or 40% have a percent. So there's room for maneuver in terms of improvement of these treatments, and we'll see how we can optimize the clinical impact of these treatments, which are anti-craving treatments in the end. Now, to answer to this question, trying to optimize the efficiency of the treatments, there are various experts who recently have issued some recommendation with regards to the buprénorphine or metformin. They stress the need of targeting the treatments with methadone and buprénorphine by reducing the craving in order to be able to reduce the risk of relapse and also reduce the phenomenon of addiction transfer. If a patient maintains a high level of craving for opiates, they will have a trend of continuing to consume or relapse, but also may increase the consumption of other substances in order to relieve those desires to consume. So this targeting will need in our clinical practice to be able to integrate and to set up an assessment, a systematic evaluation of the craving episodes, initially with the patient and also throughout the care with constant recurrent reevaluations. And we will have to find in this approach of adapting the dosage sufficiently as we have seen with rather high dosage from about 16 milligrams of buprénorphine per day to obtain a sufficient reduction of the craving episodes, and that will have a stable and durable effect over time. So you can see that the evaluation of craving in clinical practice will be a totally essential element if we want to reinforce these approaches. In practice, we have very simple tools, very efficient instruments for this evaluation based on the these scales will allow us to evaluate in the most systematic way possible the intensity of the craving episodes that are perceived and reported by the patients. And these scales also have the interests of their feasibility and the acceptability by patients, because they are tools that are very easy to use, very easy to implement in the care services, and they can be easily used by the professionals, and which will be also easily repeatable at the various different evaluations or assessments. Said this, together with this approach, concentrating on the intensity of the desire to consume, you have to be aware that the craving is an experience which in the end is a complex phenomenon which will be expressed through various dimensions. And so the craving will potentially have a multidimensional expression with emotional dimensions, also cognitive, behavioral, and also physiological. So, for example, craving, outside the fact that the patient is going to feel the desire to consume, he'll potentially be only to express through more tension, stress, and irritability, also with intrusive thoughts concentrated on the product, or the anticipation of the hedonist effects by a research of other products or taking other consumption, or more physiognomic tremors, or cardiac rhythm, heart rhythm increases. And craving is going to be similar, therefore, to an experience of stress, and will often be associated to certain significant levels of emotional distress. It's going to be an experience where the patient is going to be in a constant struggle against very obsessive and intrusive thoughts, will be able to be associated to stress, anxiety, bad mood, or even suicidal thoughts. So you can see that craving will also be able to be expressed through much more emotional symptoms or more psychiatric symptoms, with a potential impact on the global functioning of the person and their quality of life. It's going to be very important to take into account these elements when you begin the care and then throughout all the follow-up. So we have seen the evaluation by the doctor. Another important component is also to be able to accompany the patient to better perceive these phenomena in their daily lives, to better be able to detect the craving and the temporary or time fluctuations within a day. And for that, we can use observation sheets with paper, but recent data have potential. There could be mobile technologies also in the future with implications with regards to care, which will help the patient to better monitor day by day all of these episodes. It'll also be important for the patient to be able to detect the triggers in his or her environment in a very personalized way, which will potentially increase the risk of craving and therefore the risk of relapse as well. And you can see that all of these elements will constitute vulnerability markers for relapse, which can subsequently significantly help the doctor or the clinician to adapt the therapy and the care. So these are clinical markers which are more precise. Does the patient, and it goes far beyond just asking whether the patient is consuming or not. So, as has been said, there's clearly an effect of dose dependent. The anti-craving is very closely correlated to the dose, so we have to adapt the dose and to increase it in order to be able to get a significant reduction of the craving in a stable and durable way, and to be able to limit as much as possible these variations over time, and to be able to associate the therapy. It's also important to reinforce the psychotherapeutic accompaniment, which will allow the person or the patient to better manage and regulate their episodes on a daily basis with a better control of all the different determinant factors which may have been identified. Now, this slide it was borrowed from Professor Maurice de Mathies. It's a graphic representation that's very clear of the relationship between two buprénorphines and the plasmatic concentration. And here, with low doses below 16, let's say 8 milligrams of buprénorphine, you will clearly have circadian variations with an effect of end of dose, a reduction of the concentration at the end of the day. So they will look like under dosage with a possibility at the end of the day, at the beginning of the morning, to be for the patient to experience strong desire to consume, and also a bad humor, a bad mood, and irritability, which may push him to fraction the treatment over the day and to take more dose. But if we increase the dose, however, at around 16 milligrams, these higher dosages will lower the effects of the circadian curves, and this will allow an anti-craving effect, which will be stable and durable and will have a very positive effect, therefore, on the clinical stability and the clinical results also in the long term. As a result, these higher dosages of buprénorphine in articles have been associated less iterative treatment, and therefore a significant improvement. The last argument that is important, and that is the role of certain individual vulnerability factors. We've talked at the beginning about the associated psychiatric disorders. There's a study by Dipro-Banirmeni, which is assessed by patients treated by methadone, which compared the dosage of methadone between patients with a psychiatric disorder and those without psychiatric disorder. The results show clearly that the patients with psychiatric disorders will need methadone doses that are higher, and therefore will also need titration a certain slightly longer period to be able to get an optimum and efficient dose for the craving in a reciprocal way. There are also an inverse effect, so sufficient high dose will also have a positive impact on the evolution of the psychiatric evolution. and with buprénorphine, which seems to be more efficient on the stymic dimension and on suicidal thought. So within the context of these dual pathologies, we will really see some interactions and reciprocal relationships with, on the one hand, the need to increase the dose, the therapeutic dose, to have a sufficient effect on the reduction of craving. But if we have an optimum dose here, we will also have a benefit in the evolution and expression of the psychiatric symptoms, which is interesting to assess, I believe. So, to summarize, we can summarize the approach by saying that by stressing the importance of being able to systematically evaluate the levels of craving and the triggers of the craving in a very individualized way for the patient. They will have to be reevaluated in a systematic way with every visit, and evaluate also the potential exposure depending on the risk factors for the patient which have been identified for him. These successive evaluation will be very important clinical markers in order to be able to propose an adaptation, a therapeutic adaptation adapted and made to measure on these elements of vulnerability, and the possibility also of being able to develop targeted psychotherapy to better control the potential role of certain triggers. This approach normally has to allow you to get an effect on the craving that is more effective and more long-lasting, and allow the doctor to better assess over time all the underlying vulnerability factors like psychiatric disorders or reaction to stress or sleep disorders, which are more easily evaluated once the craving has been properly controlled. And globally, it should also optimize a better and more global care. Finally, I'll give you a clinical example to illustrate these different aspects. This is a patient that we received very recently in our clinic. He was a young man of age 31. He was hospitalized for addiction because of heroin and associated to consumption of crack, and he'd become compulsive after 6 months in his history. We noticed that there was an IMV suicide attempt, and if we go at the trajectory and the history of that person, it was a patient who had consumed heroin. It began in 2006. He was aged 18 with a couple of diagnosis of usage, quick treatment with buprénorphine in 2008, and then the maintenance of the treatment until 2019. And you can see there was about a little bit more than 10 years of treatment. There's a period when he stopped, when he did his military service, and then there was a period when he stopped, which was longer, between of a year and a half between. And in all of these periods, however, he maintains a consumption of snorting heroin of 1 to 3 grams, and then there was a part he consumed a bit of crack and cannabis and tobacco also, with an associated addiction diagnostic. So this is the psychiatric history. There was a psychotrauma in his teenage years, in adolescence, and in the period of abstinence, and the strong and clear emergence of post-traumatic stress disorder. We worked with that patient in a retrospective way, of course, but we tried to make a link with him in the periods with the fluctuation between the craving and the dose of buprénorphine and the levels of we assess it. We didn't evaluate the temporary ones. We tried to see in the different periods of his life the craving averages in a scale between 0 and 10. Here you can see the consumption of heroin is is what we were explained initially. It fluctuates between 3 grams, 1 gram, and this period of abstinence between 2016 and 2000, the dose of buprénorphine, clearly there were fluctuations of dose, very numerous and rapid, that can be explained by many factors, by changes in prescribers, and also the patient has a family pressure to reduce the dose, and sometimes there was another effect. There were a couple of doctors that had tried to encourage them to reduce the dose, so they maximum 8 or minimum 2. So they had fluctuated in parallel. You can see during all of this period of time there was a craving, which in the end is not controlled very much at all, and levels here of an intensity between 6 and 10 and 10 and 10, and there's clearly a correlation between the consumption of heroin. Here you can see a weak dosage of buprénorphine and a very high level of craving that coincide. And when we look at this period where he stopped, finally, if we looked at the stopping of consumption, that was we would say that that's efficient, but there are clear vulnerability markers and limited treatment because the patient that fractions his dosages, and then you clearly have an aggravation of the psychiatric symptoms with the emergence of PTSD symptoms, which will evolve to a relapse of the consumption of heroin. We've seen the evolution towards an addiction in crack. So to conclude, therefore, 3 important points: the high doses of buprénorphine of above 16 milligrams is correlated to a better control of craving, less and a better retention of treatment, and also there's a positive impact on quality of life and psychiatric symptoms. It's important to develop approaches of adapting the dose that is individualized, made to measure, depending on the severity of the addiction, which will also bear in mind all the different factors of vulnerability and the triggers also, and factors psychiatric. These elements will allow you to have an anti-craving effect which is durable and stable over time, to avoid relapses or transfer of addiction, and probably, as we said, to optimize the quality of our global approach by facilitating the evaluation of the underlying vulnerability factors. Thank you very much.
Merci beaucoup.
Well, thank you very much. Thank you to the 3 speakers. Now we have a little bit of time for some questions, and I ask you to raise your hands. There's a question there. There's a microphone that's going to be sent to you. Try to make questions as operational and concisely as possible to allow the speakers to answer. Well, I have 2 questions, very quick questions to ask. The first one was very interested about the difference of the efficiency of buprénorphine compared to methadone on the addiction costs. When you looked at the results with buprénorphine, you said that an efficiency that was bigger in reduction of consumption of alcohol, for example. So my question is, whether is that because there's an improvement of the craving, which is much more satisfactory and therefore less, or is it a direct effect of the buprénorphine on the consumption of alcohol? Which is it? Is it direct or not? And the second question, which is very short, is about what could be our means of evaluating a craving in the case of people that are in jail, because we know from our experience that there is something particularly with craving when in jail. It is sort of resting, but there is it fires up. Let's say on the days there's a bigger risk of relapse when they're about to be released from prison. So what are the tools that could be used in order to assess the craving during prison time? Okay, well, first of all, the first question, Dr. Serre, and the second question with FATSEAS. Can you hear me? Well, with regards to the first question, well, in this study, this comparison study of the evolution of patients on buprénorphine and methadone, most of the patients hadn't yet received the evaluation on craving that was set up in the cohort quite late, and so we cannot directly answer that question in these data, at least. So we can see an effect on the consumption of alcohol without being able to know whether the reduction of the craving for the craving for alcohol is a mediator or not. And with regards to the question of prison and measuring the craving in that particular, well, craving is really at rest because there's less exposure to environmental factors, perhaps. And and even if there are products that are around in jail, but symbolically the person knows that they are in an environment where basically it's not available, even if they know that it is possible. It's not a natural situation where it's a tool to evaluate that. There's no more specific tool or instrument for that situation, but we still have to regularly reevaluate all of those elements with the patient by using particularly the visual scales to see whether the patients are seen regularly, but the scales are not specific to any substance, and so they can be implemented for the different types of addiction. And also, indeed, there is an increase with the anticipation of leaving prison and anticipating exposure to something opiate. Well, if it's opiates, there's that you can adapt the therapy, and also there are all the aspects of a relationship accompaniment, of the anticipation of the risk situation, the psycho accompaniment, adapting the environment, the link with the care structures. These are, I think, all essential elements in order to be able to work with that. I don't know if I've answered your question, but indeed, adaptation of the treatment, therefore, there's a need of reassessing even that context or ahead of time what the exposure and to be able to anticipate the risk situations with the social care. And I have a brief comment. Thank you very much for the 3 presentations. They were really excellent. I would like to, you've talked about a multi-dimensional approach for the patient, and craving itself is multi-dimensional. You've said that very clearly. You've talked about the anxiety dimension, which is very frequent, and you can see the importance of adapting the treatment with buprénorphine or methadone. And there is a problem which anticipated usage, and I think you have indeed shown an anxiety disorder problem and the need of increasing the dosages with those patients, because when you control anxiety more, you reduce the craving and the consumption of other products, because you have to realize that the person is a global person who's looking for a balance, and through a treatment that will he will seek a balance with various means. You can see that young person with opiates, tobacco, crack, and alcohol, and in the end, at a certain moment in time, the patients try to self-regulate themselves depending on what is available to them, and so we have to adapt the therapy, and the persistence of co-consumption have to be a symptom. So for us, even if the patient doesn't express it, there has to be an element that says, be careful here, because here there's something that we have to work on there. Absolutely. That's why I said that in this approach, there is the existence of consumption behavior and consumptions of other products, which has to be interpreted as an equivalent of craving. Yes, I just wanted to add also, I'm at the back of the room, with regards to the question, prison, jail, and is it a displacement of craving because the patients in a prison environment consume much more psychotropes and cannabis. So this is this lying to rest of this famous craving. Well, you think it's rest, but in fact it is compensated by other things in prison. I think I agree with you pretty much, and you could monitor the consumption of tobacco, and benzodiazepine is indeed important also, and you can, without doubt, interpret it in that way. I agree. Well, perhaps the last question before we go and have lunch. No raised hands. Well, I have one little question myself, because I found all the presentations to be really interesting, all of these fascinating elements that you've been talking about, but I have a question for all the speakers. is all of this finally very specific for opiate, for buprénorphine or methadone, or are these things that exist in other addictions, for example, tobacco, where also there are some drugs or medicines that are very used? There are also substitution treatments like patches or Clean. In your various different research experiences, can this be expanded to addictions, generally speaking? And dare I mention also addictions without substance? Can it be extrapolated?
With agonist therapies, for instance, for nicotine, for opioids, we don't have those therapies for other substance use disorders at this time. I think it's easier to establish dose-response relationships and extrapolate it to the kinds of clinical presentations that we heard. I think we don't know enough yet about other disorders. There have been attempts, obviously, with agonist therapies for cocaine use disorder that have only been very mildly successful. I think with alcohol, we don't really understand that because we don't have the pharmacotherapies that are agonist-based. With antagonist therapies, I think it's much less clear, and so I think that we're on a trajectory where we can do systematic science to answer that question, whether it will be a drug-specific reduction, whether there will be substitutions or complementary use, addiction transfer, sometimes called. Do you have any thoughts about this from a clinical perspective?
No,
Well, I think indeed that we can do some parallels. You can draw parallels, but only on therapeutic with agonist models and with also a dose effect. But with regards to the clinical expressions of the craving, is it really particular to opiates, or, well, with regards to the clinical expression of the craving, it is relatively well established that it is very horizontal intersubstance. We will find exactly the same elements for different addictions of substance and also for behavioral addictions with regards to the expression and the link of the craving with the utilization or the usage. Thank you very much. I hope that this can be useful for you in your various practices. Thank you very much for applauding the excellent speakers. And so lunch is being served now at the usual place, and we will come back and start again at 2:45 punctually.